Okay, or maybe I'll.
Yeah, go for it.
I don't know. Well, it's my pleasure to welcome Dr. Dawn Castor.
No, speak there.
Oh.
Yeah.
It's my pleasure to welcome Dr. Dawn Castor. Dr. Castor received her Bachelor of Science in Nutrition and a Bachelor of Science in Sociology, both summa cum laude from Case Western in 2001, and she was a Phi Beta Kappa graduate. She completed her MD here at UofL in 2006 and then completed a residency in internal medicine and was chief medical resident from 2009 to 10. She was a clinical nephrology fellow from 2010 to 2011 and then did a research fellowship from 2012 to 2013. She's been an assistant professor in the Department of Medicine, the Division of Nephrology, since 2013. She's director of the Glomerular Disease Clinic, and she's currently involved in 4 clinical trials. She was PI on an NIH K08 award, and now she is PI on an NIH R01, ABN1 dysfunction in lupus nephritis. She's received a number of awards for her research and presented at a number of meetings, and she serves as a reviewer for a wide variety of journals in the field. She is an author on 27 peer-reviewed papers and an author on 3 book chapters. I know Dawn also as a runner, a fellow runner, and I appreciate her involvement in talking with the second-year medical students in the NIDDK T35 training program each summer. So thank you for sharing your research with us today.
Oh, thank you so much for that introduction. And with all the graduations, I'd also like to add, for those of you in the audience that are from Louisville, I'm also a Ballard High School graduate, so I am a native Louisvillian, class of 97. I'd like to go into the talk, Precision Medicine in Lupus Nephritis. And this talk kind of tells a journey of my path in research in nephrology. And I would not be here without the support of many mentors along the way. Sorry, I'm trying to advance my slides. I think it... now, I got it going. Okay, so before I go any further, these are some disclosures. I do some consulting and then on some Speakers Bureau, none of which will affect this talk. I just finished up my NIDDK award, of which part of the research I'll be presenting was conducted under that. And then I'm happy to say that I am a co-PI with Dr. David Powell on an R01 that just started last fall. And I'm also a site PI for multiple industry-sponsored clinical trials in the area of glomerular disease. So the main learning objectives of this talk are pretty broad. So I'd like to identify current diagnostic and treatment gaps in lupus nephritis. And for those in the audience outside of nephrology, LN is kind of our short name for lupus nephritis. So throughout the talk, I'll be referring to it as LN. Highlight the heterogeneity of disease in LN, provide examples of how precision medicine may be applied to LN. So first, I'd like to go over some health disparities in the disease burden of LN. So approximately 50% of patients with systemic lupus will develop nephritis. Up to 30% of patients with LN will progress to end-stage renal disease or end-stage kidney disease in their lifetime. And complete remission of LN occurs in less than 50% of patients with standard of care therapies. So we have a huge gap in treatment. There are health disparities out there as well. Lupus disproportionately affects women and minority populations. 9 out of 10 patients with SLE are women. And since I'm at an endocrine conference, I will say that there's probably a large hormonal component as lupus affects women of childbearing age. That's not the area of my research, but I have a large biorepository, so if anyone in endocrine is interested in studying these, most of my patients are women. There's a body of literature on how female sex hormones, particularly estrogen, play a large role in the pathogenesis, as well as the pathogenesis of other autoimmune diseases. And then also on the flip side, testosterone can also downregulate immune responses. Patients with African and Hispanic ancestry are more likely to be diagnosed with lupus. And when they have lupus, they're more likely to have nephritis. And patients with African and Hispanic ancestry are also more likely to develop end-stage kidney disease from lupus nephritis. So to wake you up, because it's the afternoon, some celebrity cases. So all of these celebrities have had lupus nephritis. So Selena Gomez famously came out a few years ago after having kidney failure requiring kidney transplantation from lupus. Toni Braxton has long documented her battles with lupus and lupus nephritis. And Nick Cannon, a few years back, developed an acute kidney injury that was then determined to be from lupus nephritis and actually temporarily required dialysis. I think it's really important to note these cases too, because, well, of course, they're not my patients. Lupus is a disease that's often hidden because it affects people that are young and often otherwise healthy in appearance. And because of this, it often gets misdiagnosed or a delayed diagnosis. A lot of the early symptoms are vague, but patients can have significant disease and kidney failure and look relatively healthy. But since these are not my patients, I'm going to start with a couple cases that are actually patients that I saw. And this is a patient I saw as a fellow early in training. And really triggered my interest to study lupus and lupus nephritis in greater length because I was upset with the outcome. So this case starts with a 16-year-old African-American female who initially presented with fatigue, shortness of air, normal creatinine of 0.6, urinalysis with protein in blood, which is abnormal, protein to creatinine ratio of 1.2, positive ANA, positive anti-double-stranded DNA, and low complement levels. So she underwent kidney biopsy, which showed both class 4 and class 5 lupus nephritis, which I'll be defining later, with moderate to severe activity and no chronicity. 10% of her glomeruli had cellular crescents, and she was initiated on treatment with IV cyclophosphamide, completed 6-month course, and was placed on maintenance therapy with prednisone and mycophenolate mofetil. Following her initial diagnosis, she continued to have flares. She never really went into remission. Creatinine increased to 1.2 to 1.3 and remained somewhat stable. Then she became pregnant, so probably some hormonal regulation involved in this next flare. But was taken off MMF, and 3 months later, she was admitted with a miscarriage and AKI. A repeat biopsy showed both class 4 and 5, which she had before, but this time she had 90% crescents, and crescents in the kidney, for those of you that in the audience that aren't familiar, are highly inflammatory and associated with a large amount of damage. So 90% crescents is never a good thing. She's treated with IV cyclophosphamide again, along with high-dose steroids. However, her renal function rapidly declines, and she has to initiate dialysis. Second case was a patient that I saw in clinic. So when she first presented, she presented at 36 years old with protein in blood, 7.5 grams of protein, which we would call nephrotic range, creatinine of 1, positive serologies, and then her kidney biopsy showed membranous nephropathy with IgG, C1q, and C3 staining on immunofluorescence. Her electron microscopy showed both mesangial and subepithelial deposits. She's placed on prednisone and cyclosporin, achieved a partial remission with 1.5 grams of proteinuria at 1 year. 5 years after her initial diagnosis, she becomes nephrotic again. She's placed on MMF and prednisone. Her creatinine increases, and she undergoes repeat biopsy. And this time the biopsy shows advanced glomerular sclerosis and interstitial fibrosis without evidence of disease activity. Because there was no disease activity, she was taken off of immunosuppression. But 10 years after her initial diagnosis, she eventually develops end-stage kidney disease. So this is two different cases of lupus nephritis, just showing the difference in the heterogeneity of the disease. So both of these patients presented differently. They had a different disease course and a different underlying pathophysiology. In the first case, we have a patient that had a massive amount of inflammation that led to fibrosis and kidney failure. And in case 2, we had a patient that had indolent damage over many years, leading to fibrosis. And they both had the same unwanted outcome of kidney failure and end-stage kidney disease. And both very young. So, if you're diagnosed with lupus nephritis in your 20s, even if it takes 10 years to get to end-stage kidney disease, a lot of these patients are quite young when they get there. So what is precision medicine? So it's a fancy word I put in the title of my talk. But precision medicine is an emerging approach for disease treatment and prevention that really takes into account the individual variability in genes, environment, and lifestyle for each person. And the pathogenesis of lupus is complex. So it's what we call, a complex genetic disease. There are multiple factors. And I think this is my slide of, lupus pathogenesis on one page. So you have genetic, environmental, immunoregulatory, hormonal, and epigenetic factors, which all lead to autoimmunity, which these patients develop autoantibodies, immune complexes, and then when these immune complexes deposit, you get cytokine production, T-cell activation, and eventually you get organ damage, and then it can affect multiple different organ systems. So my focus is on the kidney, and of course the pathogenesis of lupus nephritis is similar to the pathogenesis of systemic lupus, starting with the loss of immune tolerance, expansion of autoreactive lymphocytes, but there are also local factors that contribute to damage. And I'll briefly go over kind of the different forms. So you have subepithelial immune deposits leading to class 5 lupus nephritis, which the second patient had, and subendothelial immune deposits leading to class 3 and class 4, and then typically mesangial immune deposits are present in class 1 and 2, but also in 3, 4, and 5. And this is just a brief overview of the classification of lupus nephritis. I only included class 3 and 5 because 3 through 5, because these are the most clinically relevant. 3 and 4 are both associated with subendothelial deposits. The only difference really between class 3 and class 4 is the number of glomeruli that are involved on the biopsy. So class 3 has less than 50%, class 4 has more than 50%, and class 5 is associated with subepithelial deposits in a membranous pattern, often associated with nephrotic range proteinuria. But we can have combined classes, class 4 and 5 together, where they're just immune complexes everywhere, which was our first patient that I described. These immune complexes, so the immunofluorescence on the biopsy lights up really brightly, and it's what we call a full house pattern typically. So you get IgG, IgA, IgM, C1q, C3, all depositing in the kidney, causing an inflammatory response. So identifying biomarkers in lupus nephritis. So how would one go about doing that? So what is a biomarker? Biomarker is another fancy term that gets thrown around a lot in the research literature, but essentially it's just a characteristic that is objectively measured and evaluated as an indicator of a normal biologic process, pathogenic process, or response to therapeutic intervention. And we look at biomarkers all the time. So in our clinical practice, we use traditional biomarkers. So what are the traditional lupus nephritis biomarkers? So kidney biopsy. Kidney biopsy helps tell us what class, how much inflammation is in the kidney. Serum creatinine gives us a general idea of what the glomerular filtration rate and the kidney function is. Proteinuria, which can be looked at in a urinalysis, urine protein to creatinine ratio, or a 24-hour urine protein. Also an indication of glomerular damage. Hematuria and urine sediment, so red blood cell casts, acanthocytes, also biomarkers. Anti-double-stranded DNA antibodies, and complement levels. So these are all things that I order on a regular basis for my clinic patients. But there are limitations to these traditional biomarkers. So this comes from a study which looked at protocol kidney biopsies in lupus nephritis patients and demonstrated that there's a large discordance between traditional biomarkers and disease activity. So you have here patients that meet criteria for complete renal remission. So by that, it means that they have normal kidney function levels, normal creatinine levels, and less than 500 milligrams of proteinuria, no active urinary sediment. So patients were biopsied after receiving their initial treatment, and this is the activity index of the biopsy. So less than or equal to 3, 4, 5, and greater than or equal to 6. So there are patients that still have relatively high activity despite having clinical remissions. And then over here, we have patients that have proteinuria either less than 500 or greater than 500, and have an activity index of 0. And you can see that patients with no activity, some of them still had proteinuria, like my second patient. So what they summarized in this paper was that 29% of the patients who achieved clinical remission still had high histologic activity on repeat biopsy, which was defined as an activity index over 5. And 62% of patients with complete histologic remission, so no activity on the tissue biopsy, still had persistent clinical disease based on our clinical definitions of activity. So therein lies a problem. Our clinical biomarkers are not perfect. So we need something better. And what would the ideal biomarker for lupus nephritis be? So 1, it would identify those at risk for developing disease. 2, it would distinguish between active and chronic disease. 3, it would help guide choice and duration of therapy. And 4, it would be reproducible in a commercially available assay at a reasonable cost. Okay, this is pie in the sky stuff. No, there's not one magical biomarker. So obviously, it's going to take multiple markers. So I suggest that there be a lupus nephritis biomarker panel, or actually maybe multiple panels, one with genetic biomarkers, one with urinary biomarkers, serum biomarkers, tissue biomarkers. And my work to date is essentially exploring better biomarkers in lupus nephritis. So I'd like to first start with the work that I did, primarily starting with my research fellowship and then going into my early time on faculty, and that is identifying serum and tissue biomarkers for lupus nephritis. So back to the immune complex deposition in lupus nephritis. So I've already told you that immune complexes deposit in the mesangial, subendothelial, and subepithelial spaces. But where do they bind to? So the circulating antibodies can bind directly to native antigens in the glomerular basement membrane or other glomerular cells. Or you can have circulating antibodies bind to planted non-native antigens in the glomerulus. And it's debated on how the immune complexes get there. So they can be kind of passive from the circulating immune complexes, or you can actually have an antibody bind directly. Lupus is characterized by autoantibodies to nuclear antigens. And this is a study that was done on actually cadaver kidneys. That these are patients with lupus that happened to die from other causes. And they had 25 kidneys that they looked at. And they looked at traditional nuclear antigens, so anti-double-stranded DNA, anti-CLR, anti-Smith, anti-SSA, SSB, histone binding, chromatin binding. And what they found was the IgG that they recovered from these lupus nephritis kidneys actually contain a very small percentage of antibodies that bound to these nuclear antigens, suggesting that IgG is also binding to other things. And this goes to my work that I'm going to present. So we suspected that patients with lupus had autoantibodies that bound directly to native kidney proteins. So I took normal human kidney that was donated generously from CODA, the Kentucky Organ Donor Association, from kidneys that were deemed unacceptable for transplantation. And from those normal kidneys, we isolated glomeruli. And then we prepared glomerular extracts and separated those proteins on a gel by SDS Page. And then performed a Western blot with sera from patients with lupus nephritis to find out where those circulating autoantibodies would attach. Basically we're using the sera as the antibody, seeing what proteins it would react with. So lo and behold, there wasn't just one band. So it was complicated. So here I have a lupus control. So this is a patient with lupus and without nephritis. This is a proliferative, which includes class 3 and class 4, and this is a membranous lupus patient, which is class 5. I was trying to see if there was any pattern of a band that was more prominent in the proliferative or membranous to try to separate them out to find an ideal biomarker. And this is the percent of subjects with a band in these regions. And these are the regions that seem to be most specific to nephritis. So I looked at them more closely. And this is 10 patients with lupus without nephritis, 10 patients with proliferative, and 15 with class 5 or membranous. And we actually cut that area on the gel to identify the proteins that these lupus sera, the lupus patient sera, was reacting to. So anytime you do proteomic analysis, just expect to get a lot of data that you have to sift through and try to make sense of. And these were the proteins that were identified. So a total of 102 proteins that were on podocytes and glomerular extracts were identified. And we're trying to find kind of common themes and looking at proteins that had been associated with glomerular disease in the past. And then we also looked at proteins that were identified as part of the slit diaphragm. And there were 2 proteins, annexin A2 and mosin, that were of interest to me that I did further validation studies on. And we found that patients with proliferative lupus nephritis, but not membranous and not the lupus controls, had increased reactivity to annexin A2, and this is by ELISA. And we also found increased reactivity to mosin. For mosin, we also looked at staining in patients with proliferative lupus nephritis and found that there was increased glomerular expression of mosin in patients with proliferative lupus nephritis versus membranous lupus nephritis and normal controls. So both of those suggest that annexin A2 and mosin might be target antigens in patients with proliferative nephritis, but of course further validation studies need to be done outside our center. So I'm going to move on to the next part of my talk, which is looking at genetic biomarkers. So these are genes that are associated with systemic lupus. And as you can see, most are involving the immune system in some way or another. So dendritic cell functioning, interferon signaling, immune complex processing and innate immunity, T cell function and signaling, cell cycle, B cell function and signaling, and transcriptional regulation. So I wanted to focus on this area of dendritic cell function and interferon signaling because this is where my favorite gene lies, and that's TNIP1. And I'm going to go into some of our lab's work and our current work on TNIP1 and lupus nephritis. So what is TNIP1? I always love when gene names match their protein names, but unfortunately in this case, there are two different names. So TNIP1 codes for a protein called ABIN1. And ABIN1 is the A20 binding inhibitor of NF-kappa B. And you'll have to forgive me because I'm a nephrologist and not a biochemist. But essentially, ABIN1, when it's functioning normally, binds through ubiquitin binding to this IKK complex. And when it's bound, it prevents the phosphorylation of this I-kappa B alpha, which keeps this NF-kappa B in the cytosol, which is an inactive form. When ABIN1 is not functioning, this can phosphorylate, and it goes away with proteasomal degradation. And NF-kappa B then translocates, so the P65 and P50 components translocate to the nucleus, where it does all its inflammatory. Basically, it leads to the production of cytokines and chemokines. So when the complex is out here in the cytosol, it's inactive, and then this is a very simplified version, by the way. But essentially, the main thing you've got to remember is that when TNIP1 is not functioning properly, or ABIN1 is not functioning properly, sorry, NF-kappa B is upregulated. Got it? Okay. So back in 2013, and this is work I did with Dr. David Powell and his graduate student at the time, Eric Cordy, in the lab, we identified a mouse model of lupus nephritis that basically had a knock-in that affected the ubiquitin binding of ABIN1. And then along with that, we collaborated with the Oklahoma Medical Research Foundation and the SLE Genetics Consortium, called the SLEGen Consortium. And we found that while TNIP1 had been associated, SNPs had been associated with lupus, that there was also an increased risk specifically for nephritis. So we found two SNPs, this one here in African American population, the RS4958881 SNP, highly associated with increased risk of lupus nephritis, not just lupus, in African Americans. So we've taken that a step further, and we're exploring more about why this is. So we know that the knock-in mouse, because mice are much easier to study than humans, clearly has a problem with ubiquitin binding. We're not really sure what the variant's role is and why it causes this increased risk of lupus nephritis. So this is our hypothesis, is that TNIP1 variants, and specifically right now we're studying this 4958881 variant because it's more common in the African American population, and the majority of patients I see in clinic with lupus nephritis are African American. So we hypothesize that this leads to increased NF-kappa B activity, decreased ABIN1 function, B cell activation with increased autoantibody production, increased circulating patrolling monocytes and inflammatory monocytes, increased cytokine and chemokine production, and eventual increase in lupus nephritis severity and progression. Oh, sorry.
About this, know its location, is it coding
So it's non-coding, but it might still have effects, like, so we don't know. Yeah, I'm pretty sure. I'll double check just to get back from you, but yeah, that's always the surprise with a lot of these. So this is true translational medicine in practice. So I have a large population of lupus nephritis patients that I see in clinic, and they've all, not all, but a segment of them have agreed to be part of a biomarker study, and then another segment have agreed to genotyping. So so far we have been able to genotype a number of patients. AA and AG and GG are the variants we have. So the G variant is the risk variant, and the AA, I don't like to say really wild type, is the common allele. Because in humans, we don't really have wild type. We have what's more common. So actually interesting, a large percentage of my patients either have one copy or two copies of the variant, and a minority have this common allele. And the vast majority of my patients are females, and the vast majority are African American. So this is some data that we looked at in patients who we had different time points. And we looked at baseline kidney function and baseline creatinine, as well as long-term follow-up in both doubling of creatinine or the development of end-stage kidney disease and follow-up in proteinuria numbers. And we found, interestingly, and we lumped the variant, both the heterozygous and the homozygous together. So that's why there are more over here. So we found that at baseline, the EGFRs were actually very similar. And the baseline creatinine, of course, because it's based on EGFR, was similar. But while not statistically significant, there was an increased number of variant patients that experienced a doubling of creatinine or end-stage kidney disease. And similarly, there was an increased number of patients that still had really high-level proteinuria follow-up, suggesting that they were more resistant to treatment. We've also been able to identify with a bioplex, looking at the patients with the G variant versus patients with the common allele, differences in protein expression. So we collect samples of both sera and whole blood from these patients at every clinic visit, and using sera from times where patients were defined to have active disease based on proteinuria levels, we looked at active disease common alleles, active disease variants, and then we have control sera as well. And we looked at, this is just demonstrating in the bioplex which proteins were increased specifically in the variant versus control, and it gives us an idea of some of the cytokines and chemokines that may be activated in these patients. And you can see that interferon gamma is increased in patients with the variant, not surprisingly. This macrophage inhibitory protein 1 alpha is also increased, IL-16, IL-8, MIG, which is also CXCL9. Again, I don't know why chemokines have like 10 different names, but that's there. And then interestingly, GCSF, and why I say interesting, this is granulocyte stimulating factor, which any of the clinicians out there know that we actually give this in patients that are neutropenic to stimulate the production of neutrophils. And GCSF, interestingly, because a lot of patients with lupus will develop neutropenia either because of their disease or because of their treatment, I've been told by hematologists, don't give them GCSF because it might exacerbate their disease. So we thought this was really interesting too. So these are potential pathways that we're identifying in our own patient population that have the variant that may be upregulated. So I found it very exciting. So we have developed, or we're using a method that's developed to isolate neutrophils with only 7 mLs of whole blood, which is pretty remarkable because it's not a lot. And neutrophils are really finicky, so I'm going to be doing some thank yous later. But when patients come in through clinic, we actually have to isolate the neutrophils and do all the experiments the same day because neutrophils die off and they're very finicky. So this is looking at interferon gamma mediated chemotaxis of neutrophils from LN patients with and without the variant. And while we don't have statistical significance yet, we have ongoing collections. And we noticed a theme. So in patients with a common allele, there's really no response, or not much of a response to interferon gamma. But in patients with the variant, the response to interferon gamma seems much higher. Oh, I'm so sorry. I turned off my phone. Okay. And then we did have significance here. So one of the things I failed to mention about the pathogenesis of lupus nephritis is it's thought to be in part due to failed clearance of apoptotic bodies. And neutrophils have a way of killing bacteria called netosis, in which basically all they're doing is spitting out all the nuclear stuff. And they're called nets. They look really cool under the microscope. I should have showed a picture. But a lot of people feel that net production plays a large role in the pathogenesis of lupus and lupus nephritis. And we're finding that patients' neutrophils stimulated with interferon gamma have much more net production than control neutrophils. So this is just early kind of unpublished data, kind of showing ways that we are taking, the genotyping of the patients and looking more carefully at what chemokines and cytokines are upregulated, and then how their cells are acting different than controls and patients with the common allele. So we have a long way to go. We're just a few months into a 5-year grant, but so I hope to be able to show you some more data in the future. But what are some applications for this? So maybe there can be a development of lupus nephritis gene panel that identifies those at highest risk of developing lupus nephritis, and can also develop an individualized therapeutic approach based on genetic panel results. And this is a review paper by Monroe and James from 2015, where they talk about how these are some different gene variants that are known to increase the risk of lupus and lupus nephritis, and how identifying patients with those gene variants may be helpful in developing like a more targeted therapy. So interesting, TNIP1, because it upregulates NF-kappa B, which has several immune pathways. There are several suggested, potential interventions. So I can tell you that Serupimab, sorry, I'm going to mispronounce, is being studied, I think, in a phase 2 trial as add-on therapy in lupus nephritis. Eculizumab, a complement inhibitor or C5 inhibitor, is not being studied, but it's a very similar agent called ravulizumab, which is also a C5 inhibitor, is currently being studied in a phase 2 trial in lupus nephritis. Of course, none of these studies are genotyping patients. And belimumab was just FDA approved as add-on therapy for lupus nephritis on top of standard of care. But these are some of their kind of suggested, based on the genetics, may work. I would suggest beyond just the genetic SNP, really identifying what's upregulated in the population. So we're identifying right now interferon gamma and neutrophil markers, which suggests that these might be pathways for these patients. So I'd like to conclude with some final thoughts. One, current biomarkers, our clinical biomarkers that we're using, are inadequate to identify disease activity in lupus nephritis. The standard of care therapies, which I didn't go into a lot of detail, but consist of corticosteroids, cyclophosphamide, mycophenolate, result in complete remission less than 50% of the time. Novel biomarkers have the potential to help with diagnosis and treatment and also to improve outcomes in lupus nephritis. And hopefully we'll be able to eventually get to precision medicine in lupus nephritis, but it's going to take a lot of work. And I'd like to acknowledge, because obviously this wasn't done just by me, all of my collaborators. So David Powell, who's also a PI on the R01 and has mentored me from the time I was a fellow in his lab. Ken McLeish, John Klein, also wonderful mentors to me. Michelle Barati, Madhvi Rain. A lot of the work that's being done on neutrophils is done with their help. Mike Merchant, who is always helpful with the proteomics. Eric Cordy, who's no longer in the lab. He was a graduate student that kind of taught me how to do Western blots and everything when I was a fellow that didn't know what I was doing. And of course helped start the work on the ABIN project. Michaela Brady, who's currently a graduate student now, who is working on this project with us, and Shweta Tannen, my research technician. And then these are outside collaborators that without them, this work wouldn't have been done. So John Harley at University of Cincinnati, Brad Rovin and Dan Birmingham at OSU, and then our colleagues at OMRF, and actually, interesting, Pat Gaffney collaborated with us on the initial 2013 work, and now we're working with Christina Arians to increase the number of patients because they have a large cohort at Oklahoma Medical Research Foundation, and she's a rheumatologist, also working on translational research around the same age. So, clinician scientists are not a dying breed. We still exist. And Philip Cohen and Sambit Nada, who worked on the original knock-in ABIN1 mouse, and of course, the Legion Consortium. So with that, I know everyone wants to know the event code, and I will be happy to take any questions. It looks like there's a question from the chat. Sorry, I haven't been able to look at chat this whole time. So I'll take that first question. It says, how do complement levels and protein levels influence the pathogenesis and progression of lupus nephritis? And the clarification is complement levels in the blood and protein levels in the urine. So we know that when immune complexes deposit in the kidney, that complement is activated. And interestingly, serum levels of complement go down. So when there's low serum C3 and C4, generally those are markers of disease activity in lupus. Unfortunately, they're non-specific. So you can have lupus nephritis with normal complement levels, and you can have low complement levels in the serum and have no nephritis. So they're not the best biomarkers, although in general, for an individual patient, if they started out with low complement and the complement starts to rise with treatment, and then you see other markers of improvement, they can be kind of a biomarker for that patient, but as a whole, they're not wonderful biomarkers. Now, C1q antibodies might be a better biomarker of lupus nephritis than anti-double-stranded DNA antibodies, but unfortunately it's a send-out test and it's not feasible to get on a lot of patients. And then protein levels in the urine, unfortunately, proteinuria, it's kind of our surrogate biomarker for any damage to the kidney because, we think of the glomerulus as basically this sieve that's like keeping all the good components in. And we know when there's damage from whatever disease, whether it's hypertension, complex disease, or diabetes, that those capillaries can get leaky and leak protein out. Unfortunately for lupus nephritis, proteinuria is kind of our best biomarker to tell if someone has responded to therapy. But as I showed you with that biopsy study, is that there are patients that might have residual proteinuria but not have any disease activity. And that proteinuria is just probably from scarring and damaged, glomeruli, where there are other patients that might have low levels of proteinuria, less than 500 milligrams, but still have high disease activity in the tissue. And that's why, unfortunately, proteinuria is not the ideal biomarker, although it's the one thing that we're looking at in all clinical trials as a marker for response. So it's kind of the best thing we have, but it's not great.
Could I make a comment about that? This is Stanley Levinson. I learned a long time ago from the clinical chemistry book by Parnova. And what they said was, and I always taught this to the pathology residents and the clinical chemistry fellows, is that when you get any damage to the kidney, some glomeruli will become more porous and some will become more retardant, and I always used to tell them, and this is the reason why proteinuria and also creatinine can sometimes be so misleading, because it's all going to depend on how much more porous and how much more retardant and of course a lot of them will stay normal. Now, of course, as the disease progresses, they become more retardant in general, so the creatinine starts going up. But especially early in the disease, you can actually have an increased glomerular concentration rate. I'm sure you know that, but that's one of the things I always used to teach.
Yeah, absolutely. And you make a very good point, and that's why, we need better biomarkers than what we've been using for the past, several decades, because it really doesn't tell us what is going on as far as the level of inflammation and disease activity. And, it is one marker. I mean, there are studies that show that patients, for example, patients with lupus nephritis that at 12 months after their initial therapy or induction therapy, if they have proteinuria less than 700 milligrams a day, it actually is a really good predictor of 10-year outcome. So kind of early in disease, it's a good outcome measure, but in patients with more disease chronicity over time, and this is why a lot of times I rebiopsy patients, because I don't want to expose them to immunosuppression if it's not necessary. So it's helpful to biopsy someone that has proteinuria that may be residual and doesn't seem to have a lot of disease activity to see, well, is there any activity in the kidney that I really need to treat? Because these are not harmless drugs. They all come with a wide range of problems, especially corticosteroids. Since I'm at an endocrine conference, a lot of my patients develop, secondary diabetes. And that could be a topic of a whole nother discussion, but there's a lot of movement in the nephrology and rheumatology world of how we can use more steroid-sparing therapies, especially in our populations here in the Southeast. We already have a lot of patients with underlying metabolic syndrome. You throw a bunch of high-dose steroids on it, it's like just gasoline on a fire. So, any other questions? Yeah. Oh. So that's a great question. So for those outside, if you didn't hear, I'll just repeat the question. So for patients with other manifestations of lupus, doesn't matter. So we're not controlling for that, but we are trying to keep kind of some, clinical information there. Some patients with lupus nephritis, primarily that's their main presentation, and some patients will have, neuropsychiatric disease, skin disease, cardiac disease, a host of manifestations, and it's really hard to tease out. That's a great question and something, it'd be interesting to look into with this variant, if there's any association with other extrarenal manifestations, but we have not teased that out yet.
Are all these patients?
No, so the question is, are they treatment naive? So real world, most of the patients are already on some treatment, whether it's a steroid or even immunosuppression before, because they're coming into clinic at all different times. So pretty much if you come to my clinic as a glomerular disease patient, you'll be offered to be part of a biorepository. So we actually, it's not just lupus patients. I collect serum and urine from patients with FSGS and minimal change and membranous, IgA nephropathy. So we're trying to get just serial samples from patients. So we're capturing patients in all stages of disease. So you're getting them early, in treatment, and then in remission. And for these patients, some of them will be newly diagnosed, some of them will have had the diagnosis. But the vast majority are on some form of immunotherapy.
Sort of a follow-up to that is the first patient to is only 16.
Yeah.
Is there any to identify somehow pre-SLE in the pediatric population? I don't know. Then what would you do? Some sort of inhibition of autoantibody, and we don't even know how that happens.
So that's a great question. So the first patient that I presented was only 16, and my encounter with her was a couple years later when she presented to the hospital, because I am an adult nephrologist. And is there any way to screen or kind of identify patients with lupus before they present? And unfortunately, there's really not a good tool. Antinuclear antibodies they're very sensitive, but they're nonspecific. And it'd be expensive to just get ANAs on everybody. Now, there was a wonderful study, I think it was on actual VA patients, because the VA has just great data. And I'll have to get the study for you, but it was in an adult population. And they actually looked at blood from patients that had developed lupus, and they identified patients that had positive ANAs. And the ANA can precede the diagnosis by several years. So we do know that those nuclear antibodies can form well before the disease presentation. That being said, there are patients that have antinuclear antibodies that never actually develop lupus. And lupus I said it was a complex disease, but it's also a very complex diagnosis. So I didn't show this, but the American College of Rheumatology has a whole criterion of what defines lupus. And it's not just serologies, it's a combination of serologies and clinical factors, and you have to accumulate several to be diagnosed as having systemic lupus. So diagnostically, lupus is still a challenge. Yeah, so biomarker differences between male and female. So I think that there are definitely people that are working on some of the hormonal regulation of the immune system, and there's definitely a lot of data that shows that autoimmunity is more common in women, especially specific autoimmune diseases. And that's a very complex thing. So, with lupus, it's probably a multi-hit process. So it's not just, for example, my favorite gene, it's not just this TNF1 mutation or variant. It's probably a combination of someone with multiple risk variants affecting their immune response, possibly an environmental trigger. For example, EBV infection has been associated with lupus, and then hormonal triggers. So definitely it's more likely to occur in women of childbearing age. So there's probably an estrogen component to the immune response. So it's like this perfect combination of factors in one individual patient that leads to that patient developing lupus. And they might have an identical twin that definitely has an increased risk, but it's not 100%. So very challenging disease to study. Any final questions?
Dawn, I have a question.
Oh, yeah, sorry.
Great review.
I'm like behind here. I'm short.
I enjoyed your talk. So, my experience with and seeing all those women, all like, so something just like the sickle. What is the area like Louisville where we don't have a down like a higher percent of that ethnicity or race? And
Yeah.
then the Hispanic, which that also issue.
Yeah, so there's certainly like the SNP we're studying has been associated with increased risk in the African American population. So there's probably a genetic component. Also, as far as kidney disease risk, because the kidney disease is much higher in African Americans, and the risk of progression to end-stage kidney disease. There are some kidney-specific risks. So APOL1 is a variant associated with many forms of kidney disease progression. So so APOL1 was first associated with non-diabetic kidney disease, but then they actually looked at progression in patients with lupus, and it probably affects the podocyte stability. So these patients are more likely to have podocyte damage over time, and higher proteinuria levels, and then scarring over time. We're still trying to tease that out. There's also environmental factors that can't be dismissed. There's access to healthcare. There's certainly social factors. So I like to think of these two things as separate. So there's the genetics of ancestry, and then there are risks specifically associated with race. And some of those risks that are associated with race are due to poor access to care, later diagnosis, issues, unfortunately, with the medical system where patients are being dismissed and not, their complaints are not being heard. And lupus is a very important disease to me to study because it does affect, young women in general, and a lot of times they're young women, and that's why I showed a picture of Selena Gomez and Toni Braxton, but they're young women that look healthy. So a lot of times there are complaints of joint pain, and, they're very nonspecific. Fatigue, you have to check a urine, you have to look for the protein. So I think the best thing, while we can't screen everyone with ANAs, is for clinicians to listen to young women that are complaining of joint pain or arthralgias, and screen for something like lupus, because there's a big delay from diagnosis to treatment. And the longer that you delay diagnosis in these patients, the less likely they'll respond. So, but as with many diseases, it's multifactorial, and it's job security for anyone in research, because there's so many ways to look into it, and it is really important. And I know you mentioned the sex hormones. I have a biorepository, so if anyone from endocrine is interested in looking for markers, come to me. I'd be happy to collaborate. All right, thank you so much. I hope that was helpful. I appreciate it.
That means